think we're almost to Michigan time. Is this thing on? All right. Welcome. Hi, everyone. Christian Verkler with the Clinical Ethics Program at the Center for Bioethics and Social Sciences and Medicine. Welcome to Bioethics Grand Rounds. We are really lucky to have Devan Stahl with us today. She was kind enough to drive over from Michigan State, where she is a an assistant professor of clinical ethics and an adjunct assistant professor in their Department of Philosophy. Devan went to UVA for undergrad. She went to Vanderbilt to get her master's in divinity, and she studied under Jeff Bishop, who we were lucky enough to have up here and to give a Bioethics Grand Rounds, down at St. Louis University, where she got her PhD in bioethics. She's going to talk to us today on what to do with miracle language, and I saw her give a version of this talk at the American Society of Bioethics and Humanities meeting last year, and it was a packed house, and everyone was really riveted, and that's why I thought that you guys would really enjoy this. So please help me welcome Devan. Thanks so much for coming.
Right, move this over here. Figure out how to, okay. All right, so thank you so much for having me. I'm gonna have to, I think, maybe lean into this awkwardly. So I just have a few learning objectives today. So I want us to be able to, by the end of this, classify and distinguish between the most common ways patients and families use miracle language. I want to describe the ethical tensions that emerge when families request that clinicians continue non-beneficial care in the hopes a miracle will occur, and identify a set of strategies for productively engaging patients and families who expect miracles. So here is our quandary. What do we do when patients or families invoke miracle language? And more specifically, they're making treatment decisions based on their hope for a miracle. And I'm going to be talking mostly about end-of-life cases, because I think this is really where tensions arise. When people expect miracles, or their surrogates are expecting miracles, and really they're pushing for aggressive end-of-life care based on that belief. So this is a conflict I think will remain in our medical systems because of Americans' beliefs in miracles. In our national surveys, about 79% of people believe that miracles still occur today, and more than half think that divine intervention could save a person from death even when a physician is arguing that death is imminent. Moreover, surrogates who believe that God is capable of miraculous healing are more likely to doubt a physician's futility judgment, and are more likely to request continuing aggressive end-of-life care despite a patient's poor prognosis. So at the same time, we know that patients and families who say that their spiritual needs were met in the hospital are more likely to have a higher quality of life, enroll in hospice, and receive less aggressive end-of-life care. So clearly there's a need for our clinicians to continue to engage the term miracle and work with patients and families well when they have this expectation. So of course we know that whatever people mean by miracle when they invoke it can be highly variable. So in medicine, there might be at least 3 ways you hear miracle being invoked. It could be a really benign statement. So it would be a miracle if I could keep my breakfast down. Not meant to direct care. It could be hopeful, but maybe not expectant. So it would be a 1 in a million chance that this cancer drug will work. It would be a miracle. So it's expectant, or it's not expectant, but it's still maybe a hoped for outcome. And then there are folks who are both expectant and hopeful. So I know the doctor says that this is futile, but I'm sure that God will work a miracle and this will work. And in my experience and many of my colleagues, anyone of any faith can certainly invoke a miracle, and maybe people without a particular faith tradition. But I think this is most commonly seen in our Christian patients, partly because Christians tend to democratize miracles, so believing that really anyone can receive a miracle as long as they're faithful. And of course, we can't forget that our medical institutions participate in this kind of talk of miracles. So maybe our doctors are saying this is a miracle drug, our headlines are saying this is a miraculous recovery. The public hears this and it reinforces their understandings of miracles. And I worked, before I came to Michigan State, at a hospital whose tagline was this. I was not there at those meetings when they decided that this would be the advertising campaign, billboards all over the city. But how can we expect our patients not to expect miracles when this is what they see as they drive down the road? So we are culpable in that kind of expectation for a miracle to occur. So I am not by any means the first bioethicist to say that this is an issue that we need to deal with. When I review the literature, there are at least 3 kinds of responses that ethicists have to families or patients who expect miracles, and that's driving their care decisions. So there's a group that thinks that you should really tackle this head on. When patients bring up miracles, you might want to actually try to change their minds, either their theology or their understanding of what the miracle really is. So this is a group who thinks that you need to reframe the miracle into some other miracle. So for instance, is it really the miracle that all of the patient's families came here today to help their loved one? Maybe that's the real miracle here. And so they're trying to convince a family that maybe their understanding of the miracle is wrong. Then there's a group who thinks, absolutely not. Never engage theology directly, because it puts you in competition with another person's God, and that's never the place you want to be. So this group of folks will say, actually you should try to reframe everything in terms of hope. We all can believe in hope, and if we can talk on those terms, that's a better position to put yourself in than arguing theology. And then there's a group who thinks, first we need to discern authentic faith claims from denial. So there are people who invoke miracles because that's their genuine belief system, and there are people who talk about miracles because they're in denial about their care or their status or that of their loved ones. So I think there's a few shortcomings of all of these positions. And the first and probably major one is that, they seem to talk about miracles as if they already knew what the patient or their family member meant when they said miracle. But like I said in the beginning, people can have all sorts of expectations or understandings of what a miracle really is. And until we know that, it's hard to sort of train or talk with them. And then I think that there needs to be a lot of justification for arguing with somebody about their faith or their theology. So I trained as a hospital chaplain. This is something I never would have done. It's sort of taboo. You don't tell someone that their understanding of God or their understanding of their theology is wrong. Or at least it requires a lot of justification to do so. So instead, some colleagues and I from Vanderbilt have put together this kind of taxonomy, this way of maybe parsing out different ways in which our patients or their surrogates might talk about a miracle. The first way is just an innocuous kind of statement. So again, it would be a miracle if I could keep my breakfast down. So here people are just using miracle in a sort of more common way as a spectacular event or fortuitous event. So I'm not going to talk too much about that because I think we kind of know that when we hear it. We might want to inquire what somebody means, but sometimes miracles just sort of thrown out to mean something else. But then there's 2 other kind of categories. I've called them shaken and unshaken with reference to how this impacts the invocator's faith. So does it shake up their faith or does it not when they're using sort of this kind of language? And within the shaken category, there's 2 subcategories, this existential category and tragic. For the existential invocator, they're asking you questions like, why is this happening to me? What is God doing in this situation? Where is my miracle? So these folks maybe don't know what that miracle event would look like, but they are raising kind of existential questions as a result of their illness. And they're not trying to use religion as a trump card or a strategy. They're genuinely sort of upset or confused about what's happening to them. And they'd be willing to engage you in conversation or self-reflection about that. Now, these folks have been shaken by their illness or their hospitalization, but eventually they're able to shore up a new conception of self and their circumstances. The tragic invocator, however, will not be able to do that. They'll remain fragmented by those particular experiences, and they'll pose existential questions that will go unanswered. And so their conception of self really remains shaken. And of course, an invocator can move in between these two categories depending on whether ultimately they're able to come to a new sense of self or not. In the unshaken category, we're talking about folks whose conception of the world and their faith has really not changed as a result of their illness or hospitalization. So for the integrated group, these are folks whose individual conception of illness is fully integrated into their worldview and their ecclesial tradition. So their end-of-life events have not shaken their worldview. They have probably a long-standing relationship with their faith community, who provides them social support, acts as their interpreters of the world and of revelation, and are an authoritative source for their world formation. So invoking miracles for this group isn't a sense of coping. They're not coping with something by invoking their religion. This is an application of a really long-held worldview onto this particular circumstance. And for the strategic invocators, it's a little different. So this is not for them an expression of a long-held worldview. They're using the term miracle to carve out a space beyond medicine's reach. So they're using religious language for non-religious interests. And most often this is preserving or gaining decision-making authority. So for these invocators, the hope for a miracle is more ad hoc. They're not struggling with their relationship to the divine, and they're probably not rooted in a particular religious tradition. So, if you ask them about it, they might not be able to tell you a lot of specifics about what it is that they believe, or if they belong to a particular faith community. They're more concerned about their rights, and they're using that as a way to get what they want in a medical situation. So today I want to talk mostly again about these shaken and unshaken miracle invocators in end-of-life situations. So I think how we should respond as either ethicists or clinicians or chaplains is to the patient or their surrogate. When they use the term miracle, we have to tailor our responses to what category they're fitting into. So if you want to know which category maybe this miracle invocator fits into, you got to ask some questions. So minimally, what do you mean by miracle? And do you have a faith community that can support you during this time? So for a shaken invocator, this question of what does a miracle mean to you will be met with skepticism or uncertainty. They may continue to seek a miracle, but they're not exactly sure how this hope is influencing how they're choosing their care decisions. For unshaken invocators, they're clear what they mean by miracle, but once again, for one of these groups, it's an authentic faith belief, and for another, it's a power play to gain authority in a situation. So when we encounter any one of these groups, there are two things that are always required: empathetic imagining and assessing the invocator's understanding. So empathetic imagining is the process of setting aside your own conception of the world and what is right and what you believe, even about miracles, to really engage the patient in what it is that they're understanding. And for this, you need to know something about their physical circumstance, their psychology, their family, and their social circumstances. And you need to ask things like, what's important to you? What does a miracle mean for you in this situation? What would you do if you couldn't do the things that you loved? So like any kind of conversation, we're trying to elicit values from a group. So during this kind of empathetic imagining, you might hear the invocator state incorrect or incomplete medical information. And so when you respond to this, you have to determine, are they failing to understand the medical information? Are they simply disagreeing with the care team's portrait of the patient? Or are they understanding everything? They just come at it with a completely different worldview based on their religious beliefs. So clinicians should respond to shaken invocators by helping assist in the process of finding and creating meaning. You should help them shore up their moral world by facilitating self-reflection, or minimally try to help them avoid the tragedy of losing their self completely. Other care professionals will probably play a big role in this. If you're uncomfortable with religious conversations, chaplains are a great resource, as are many of our ethicists. So in this unshaken category, strategic invocators are intending, again, to use religious language for non-religious interests. And underlying this may be a mistrust in the medical system. And I want to say that this mistrust might be justified. So people want this power play because maybe they've had bad experiences in the past with medicine or in their healthcare system. And you need to sort of know some of that history to understand maybe why they're coming to you aggressively, they're insisting on their rights, and this power play comes from a place of sort of bias and hurt feelings as a result of a past experience. So for this group, it's most helpful to try to rebuild trust. You'll want to use their name, sit down at eye level with them, and always give them an active role in the conversation. So don't let them be passive when you have conversations with them. They need to be active in helping to decide what's best for usually the patient if they're a surrogate. So I think it's also helpful if we try to set timetables with folks when they're being really aggressive and insistent. Talk about what you are willing to do, what you're not willing to do, and a timetable for what the care plan is next, and then check in with them whether that works or doesn't work. For our integrated invocators, I think clinicians should be conversing with their religious leaders or authorities in their church. So this is, it can be precarious. So just because you bring it, if you think somebody is having a religious belief that might not meld with even their own tradition, sometimes you're right and sometimes you're wrong. So sometimes a faith leader will come in and say, well, yes, that's exactly what we believe, and now you're gonna have to do it, which sort of puts you in a box. So I say do this with caution, but even if that is what they say, I think it can help the care team really learn where this patient's coming from and how authentic these beliefs really are. So even in that, it's helpful. And I think that there are at least two practices that can yield ethically acceptable solutions. So first, the care team might want to work with the invocator and their community to establish, again, time-limited trials for specific interventions. Concrete goals are either met or missed within a mutually acceptable time frame with specific expectations for outcomes. A second practice can be working with the patient's conception of death. So even if latent, most miracle invocators understand there's a difference between the living and the dead. And if you have, I think you first have to have a good relationship with this patient or this surrogate to ask this. But if you do, I think it's okay to ask, I'm gonna ask you a hard question right now, but I bet it's one that you've thought about before. What does death look like to you? Or what does dying look like to you? And so maybe they don't have a specific answer to that and you need to prompt them. Some people would say that if their heart's no longer beating, then they're dead. And some people would say if their blood pressure dips low and they're struggling to breathe, then they might be dying. So have you thought in this context what death looks like? And I think that this can help just sort of place limits on what it is that you are willing to do for a patient. If they have a conception of what death really looks like, how will they know when the patient is dying? How will they know when they've gotten that far? So I want to pause at this point. I have some case studies that I think kind of highlight these things, but I want to see first if there are any questions that you have or any sort of stories you want to relate. Maybe I've been really clear. No? Okay. Okay, so I'm going to give you a case and then ask you what type of patient you think this is and how do you think you should respond. So Mr. C is a 30-year-old Hispanic man with short bowel syndrome. Being unable to take sufficient nutrition by mouth, he has lived his adult life with a J-tube for daily TPN. Mr. C has decided that he will not continue with the J-tube and requests that his surgeon remove the tube. He says, I don't want to suffer like this anymore. I want to seek the kingdom. I don't know what God wants from me. If a miracle occurs and I change my mind, God saves me or some new, better therapy comes along, then that's fine. But I think I would rather starve and die than continue like this. So if this is my lovely table, what kind of invocator is Mr. C? Okay, I'm hearing, I heard maybe integrated, maybe strategic. How do you know? What evidence do you have? Or what questions would you want to ask to help figure it out? He said the word kingdom, so he's definitely invoking really specific religious language. So maybe you want to ask him what he means by that. So maybe you have a sense, so a lot of us, if we come from a Christian tradition or a tradition that uses words like kingdom, we might jump to the conclusion that we know exactly what he means by that. I think that would be a mistake. I think we should probably ask him first. Yeah.
I would ask what a J2 means to him.
Okay.
What kind of problems did he encounter? How was he suffering exactly?
Mm-hmm.
And go from there.
Okay. Yeah, so what if he tells you, this is just such a burden, it's unattractive, it's, it doesn't cause me a lot of physical suffering, but it's just a bear, and I just don't want to live like this. I'm young, but we just had a case like this. My girlfriend really doesn't like it, and I just don't want to do this anymore.
So it disrupts his sense of self,
Mm-hmm.
of who he is, or who he wants to be, and how he wants to appear to himself and the world.
Mm-hmm. Right, so it's caused him some sort of existential strife, right? Like it's disrupting who he thinks he is or who he wants to be. And so it's that in and of itself is posing a kind of suffering on him. So maybe, he's young though, so it makes us nervous, right? We're not pulling J-tubes out of 30-year-olds typically, unless they have a really good reason for it. So I've actually called him, at this point at least, an existential invocator. He's bringing up religious ideas. He's not super specific about them. Really, he's lost his sense of self. So what do we want to be able to do for him? Once you inquire, he's really distraught about this. What's your next step?
Ask about what he imagines what would be his life, what would be the future, that third question there, asking to imagine.
Yeah, imagine with me, if you will, what's sort of the best case scenario? What's the worst case scenario? What do you hope for? Who do you imagine yourself to be without this? Is death worse than this? I mean, there's lots of questions we can ask to help him sort of really, we want to make sure that he's done some self-reflection, that this isn't sort of a gut response to some other incident that's happened. What else might you want to do?
Have a psychological assessment for depression?
Yeah, maybe. He's certainly saying things that sound not super rational. Maybe this is coming from a place of depression, so you might want to check that out.
What does he imagine will happen when you take the J2 out?
Yeah, does he really understand? Yeah. Yeah, we want to make sure that he really understands the consequences of taking that out, because they could be rough.
And have all the other feeding regimens been explored? Has there really been a thorough assessment of the different feeding regimens that he might be able to undertake?
Absolutely. So sometimes if somebody's had something for a long time, we just assume it is the best option for them. But maybe there are other options to explore.
So I think in terms of forward thinking, hoping to find hope in what could be, it's what you value today, what is bringing you joy today. So like obviously there are things that are going on that are making you become unhappy with the J2, but then also trying to bring you back to the present moment and thinking on things that are positive in your life.
Yeah, so what do you value? Sort of reframing what it is that brings him joy, and hopefully then that brings more hope. Yeah. I think it's also, he's sort of invoked this religious language, and we haven't asked him whether he has a faith tradition. Maybe he actually has a pastor that would be really good to talk with him about this even while he's in the hospital. And that's something that's pretty easy to do, to just call his pastor. And maybe that person can help sort of reframe this. Unless he belongs to a religious tradition that doesn't believe in medicine, you can imagine that this is the kind of person who might encourage him to continue to seek care if that's what he really maybe ultimately would want. Okay. Case number 2. Mrs. A is admitted to the MICU due to respiratory distress related to complications from pancreatic cancer. She's placed on a ventilator support at And at day 25, the team tells Mrs. A's husband that supportive treatment has become inappropriate because she has a terminal, irreversible condition. Mr. A says, "We must begin a new round of chemotherapy, continue on the breathing machine, and start dialysis as we wait for God to perform a miracle and restore her to a happy, active life. She would have wanted it. Our bishops say it's the right thing to do, and we always listen to our bishops." So what do you think? Okay, I heard strategic. Integrated. I think it's a debate between the two sides of the room now. So maybe you're not sure. What would make you think it's strategic, for those of you who said that?
He's being very manipulative in the way he's presenting the information on what he wants to be done, using his bishop's information to make that decision.
Okay, so he's very insistent and very clear about what needs to be done now, not what the doctors think. He knows best, and he has potentially support amongst another group. So for those of you who thought it was integrated, why is it potentially not strategic? Why would it be an integrated invocador? Yeah.
Well, before that, I would ask him about his previous happy life, with his wife, because I suspect behind there is overwhelming kind of sadness and grief that he could not tolerate. So one way is to help him to open up by not directly addressing his sadness and grief yet, because I don't think at that moment he could deal with it. But just ask him to talk more about, what kind of happy life he wants to restore his life with his wife too, and what it was like, and then take it from there, and maybe step by step with the empathic listening, he might start talking about the sorrow of losing her, the change, and what it might mean.
Yeah, certainly matching his aggression is not going to be the best way to get him to change his mind, right? So what made you and your wife happy? What was your relationship like? What do you want to restore her to? And maybe in the process of that, you learn either, me and my bishops, we've had a long-standing relationship. They inform the decisions I make. Or you learn, no, we don't really have a religious tradition. I'm just insisting on this because it felt like that's what was going to get me what I wanted at this point. So sometimes people will claim that they have the backing of their religious tradition. It's actually, though, typically pretty easy to figure out if that's true or not, because you just ask to invite them in. And if they absolutely refuse to invite in the people they say helps them understand everything about the world, then maybe that's not true. But if people really have this relationship with their community, one of those bishops is probably going to show up, right? Especially if you call. At least somebody from that community hopefully will show up. I say that it's, sometimes people belong to really big congregations that just don't have, the resources, or the pastor, him or herself, can't come because they're just a little busy. But hopefully they have somebody from that community who would be willing to come and talk with them. So that's something you can figure out in the course of just kind of an empathetic conversation with them. So let's say they do have this community support. What do you do then?
Set those limited checkpoint milestones where it comes to agree. Can you go back to the?
Yep. Yeah.
Maybe this is more of a specific comment than you see. I think, it's a position you can't be compelled to do something that's just medically wrong. So if you come to me with a broken bone, you can't insist that I do bypass surgery. If you come to me with pneumonia, you can't insist that I put a cast in arm.
Right.
So these are specific treatments he's seeking. I think that the other thing that I find when people start invoking miracles is to acknowledge that, sure, if you believe in that, then I certainly won't contradict your belief. It's trying to fight, how many angels can dance on the head of a pin. But I think a miracle is going to happen. I acknowledge it's going to happen regardless of what we do. So I always argue that we should continue to focus dealt with situations like this. I'm an ICU doctor. I'm a term miracle invoked. I would say not infrequently, even though my English teacher would tell me that's not correct. Now and again, and I, from working with our hospital chaplains, I've learned ways to kind of dance around it without actually addressing whether or not a miracle is going to occur. Just acknowledge that if it's going to occur, it'll occur, whether we pull the tube out or not.
Right. Yeah, and if I were doing this as a role play, which I'm not because there's just one of me and it would be just very chaotic, I would have as a doctor tried to say something like, well, I don't believe in miracles, so we're just gonna, obviously not the right thing to say. So I think a line I often hear, which I think is helpful, is, I'm not gonna do anything to prevent a miracle from happening. At the same time, I have professional obligations that I need to uphold and that I think would be best for my patients. And here's what they are. I meet a lot of ICU physicians who will come to me in a lot of distress because they just don't feel like the surrogate is listening, that they're asking for things that are inappropriate. And I'll sometimes say, well, have you told them how you feel about that? And they'll often say no because they think it's inappropriate. But I think bringing up your professional obligations and how doing this aggressive treatment makes you feel isn't inappropriate. It can be helpful for the family to hear that because maybe they think, really, I'm leading the charge, whatever I say goes, and they don't think about the other side of that, about how it might be causing our clinicians distress to be giving care that they actually think is medically inappropriate. So I think that those are really good ways to start that conversation.
Kind of sterilized death in our modern society. For the vast stretch of human history, people lived in caves and huts and watched their aunts and uncles and brothers and sisters and parents die. And it's only in the last 100 years or so we've taken death out of the home and made it the sterile hospital phenomenon, and most people's experience of death is what they see on TV and movies. And I often find it useful to ask them, what do you expect death to look like? Because most of the time they have given very little thought to that.
Right, and I think, so you're just echoing what I thought was also good wisdom. What does death look like? I think, I don't think that that's the first question you ask, because I think it could be taken pretty offensively. Well, what do you think death even looks like if it's not this? Yeah. There's probably more gentle ways to bring that up, but it's not the first thing you say. Yeah.
So this might be kind of a version of what you described as strategic, but what I see a lot, I don't know if you have an example like this, where sort of in the world of kids, it's usually with young parents who are themselves not very religiously observant, and sort of things have been going okay, and then as the family starts to come, someone like either their parents or their siblings or someone with a stronger faith will come in. And then you get this sort of abrupt turn and where it hasn't been before, you get particular comments about this. And sort of, in your work on this, do you have any advice as to how people see that, like what they actually believe versus what someone has now told them that they should?
Yeah, this can be very difficult, especially if you're talking about, a patient who didn't bring it up him or herself, but then suddenly a surrogate's bringing it up and it's all anyone can talk about. I think that this actually happens fairly frequently. So sometimes I think it's helpful to get that person out of there and just really talk with the patient, him or herself. I mean, it's depending on the age of a kid, that might be a weird thing to do, but sort of an adult or an older child, is this really what you want? Can you tell me about what this means to you? Because sometimes they just feel a tremendous pressure, especially if you're at the end of your life potentially, and someone is telling you that if you don't get right with Jesus, you're gonna go to hell. I mean, that is, you're already in such a vulnerable position. I saw some giggles, but that happens all the time, right? Like somebody comes in and says, you're not right, and bad things are gonna happen to you when you die. What a horrible burden to place on somebody. And that, it's not easy to brush that aside, especially if you have some background in that same religious tradition. So, talking to them individually, calling in that chaplain maybe to talk to them and the surrogate individually. I know chaplains don't like to be called, or at least I didn't, at the very last minute when there's basically nothing else that can be done. And as an ethicist, I don't really like that either. Like, we have tried everything and failed miserably. Let's call the ethicists because they're miracle workers. And we're not either. So, getting people in early, where's that chaplain early on so that they can establish relationships with all of the family, with the patient, sort of separately, to have potentially separate conversations.
So is there a trust dynamic here as well, in the sense that we're in an ICU, there's a lot of toys and technology, all of that technology has been used for this day, and all of a sudden the doctor said, we're not using it anymore. To what extent does that when you say, what do you think about that? Their answer could be, I think about that means you're withholding life-saving treatment.
Yeah, and then maybe that opens up a great conversation about what medical technology can and can't do and what it's doing to this particular body at this time that's artificial. But absolutely, I mean, in my, when I was sort of starting out as a young chaplain, I think what was most surprising to me is how death looked. Dead people didn't look any different than the people who had been on all those machines for such a long time. So the only reason I knew is because a nurse came in and turned the machines off. And there was no more beeping anymore. And I thought, wow, it just, regular people don't know the difference here when we have all this technology. So helping them to understand what all that's really doing and what death can look like optimally, I think that's helpful because like you've said, pop culture doesn't give us a really clear expectation of what that death is going to look like, especially with all our technology. Yeah.
Do you have any suggestions for what I call the case on health, where we have the ethics committee, where their belief in a miracle included the idea that God would not work a miracle if we discuss this at all? We must have this absolute faith. So we refuse to discuss it on the grounds that would prevent a miracle from occurring. What do you do then?
So, yeah. But they're insisting on very aggressive treatment. So I think it's pretty irresponsible to insist on a treatment when you don't understand what that treatment's doing or what its benefits are. I mean, if they're refusing to have conversations, then they're not actually really understanding what the technology's doing. And in that sense, I don't know that you have to continue with treatments that don't make medical sense to you just because the patient or the family, probably the family in this instance, refuses to even learn about it. I mean, at some point, we probably all need to have really great non-beneficial treatment policies, futility policies that allow us to say no. I mean, I think this is sort of the end stop is you do everything you can. It's not the first thing you do. You don't charge in with a futility judgment. But if you are just at an absolute roadblock, there might be appropriate instances. And when you say, this is not benefiting this patient, we're potentially torturing this patient until their death, and that's irresponsible. And so we're gonna, bring it to the ethics committee. Hopefully they'll agree with you, and sometimes then you're just allowed to say no to stuff. But I think that's hopefully our last option. But you get there, or you remove the surrogate. If they are just making decisions that absolutely go against the patient's best interest, as far as you know it. Again, a last case scenario. They're just doing really bad things to this patient. You have good evidence to know that maybe this isn't what the patient would have wanted. I think there are ways to remove surrogates as well, or at least remove, the person who was placed in charge legally.
Well, it seems to me that the central issue, in order to have Mr. A come around to see our point of view, we have to convey to him in some way that we understand where it's coming from. It seems to me the central issue is that, the wishful miracle is his way of trying to cope with the feeling of hopelessness in face of not being able to do anything for his wife, and also the sorrow underneath that's too much for him to deal with. So I myself would sort of use my empathy. Another tool would be to just talk a little bit about how people in general that I know about in this situation, in similar situation, would feel very hopeless and very sad, so overwhelming. And so the wish for miracle on his terms is very understandable. And I would even say, we wish we could do that for you. And it must be very disappointing that the reality is such that we cannot, and to do what we asked to do, not only would not bring about a miracle in the way that you wanted, but would increase, extend Mrs. A's suffering. And I would stress that, and then see how he responds. That takes time, and I understand that time is something that doctors a lot of times don't have. And so we're in this kind of tension between the wish to be empathic and helpful and try to really step ourselves into the shoes emotions of the patient and the family members on the one hand, and our need to just get to do what we need to do on the other.
Yeah, I mean, I think that's a great point. So all of this takes time, right? If you don't have it as the physician, call the chaplain and then debrief with them. Because it might be that he's feeling helpless and hopeless and sad. It could also be, and I think this is rare, but sometimes this is genuinely what I believe. And I'm actually not hopeless because my faith tells me this. I am compelled by my faith to seek this, and it would be faithless for me not to. And so that's a different kind of invocator there. So the strategic invocator might be different in that sense than if this is a truly integrated invocator who really believes this is the demands of my faith for my wife, versus somebody who's grasping at straws to get any sort of power they can because they're feeling so helpless in the situation. So depending on who this person really is, and the only way to figure that out is those longer conversations.
When you call the chaplain, is a very nice idea, but some patients might experience it as though the doctor or the health professional didn't care or couldn't deal with it. And just,
Yeah, it's passing it off.
Situation over to somebody else. And that really disrupts the doctor-patient relationship and also makes the patient feel abandoned or the family feel abandoned.
Yeah, that's a good point. So you have to be careful when you're trying to hand off to somebody who might have more expertise. How do you do that in a way that doesn't feel like abandonment, doesn't feel like you just don't want to deal with these other kinds of problems you don't know how to deal with, even if maybe you don't. Yeah, finding a graceful way to do that.
I guess I have a related question along that line, is that because these are invoking, kind of talking with the chaplain, but what if they're, or with their pastor, but what if they say, no, I don't want you to reach out to my pastor? I mean, because with HIPAA, you can't do that.
Oh, sure, yeah.
So what do you do in that circumstance when they're very much using a religious argument, but at the same time not allowing clergy participation?
Yeah, and so in those cases, like I said, I don't think that then they're probably this integrated type. They're probably then that strategic type who's using this as a kind of a way of coping with what they see as a situation where they are losing power and control. And so then you deal with them differently. So, they don't want to talk to a chaplain, they don't want to call in their pastor. Well, this is probably then not like a long-held world belief being applied to a situation. This is something else. And this is then mistrust of our medical team for whatever reason. And then the strategy, I think, is different. So you're delving into their worldview and what they believe, not as helpful here, but talking to them about, what their loved one meant to them, how much we care about their loved one, how much, we really need them to help us to understand because we trust them more than anybody else to tell us about this person. I mean, trying to sort of build trust with that person is a better strategy than continuously calling in a chaplain they don't want to talk to.
The situation where, this would be, I guess, an integrated scenario, where you call in the spiritual leader and that makes a polarized situation more polarized.
Oh, yeah. So all the time this happens, right? So I'd say, I don't know, in my experience, 50-50, that this religious leader is going to help and help. I don't want to make it seem like it's always bad when they want more care because of their religion. But if they're insisting on sort of non-beneficial care because of a religious belief, that usually is a problem. So you call them in, you try your best to talk with that sort of faith leader with the person there and maybe separately. I mean, sometimes just getting them in the room to see how bad the patient really is helpful because they can't really know that from an outside perspective. So they just sort of hear, oh, well, I heard he ate today, and so he's fine. But really getting them in there shows a different story. If they're continuing to insist, then they're part of the coalition of this group that really wants to continue care. And I think you just treat them then as part of that community, and then you do the same sorts of things you would have done otherwise. Here are our professional obligations, Pastor. I hope you can understand. You have yours, I have mine. Here's what it looks like. We're not trying to prevent anything you do or get in your way, and it's helpful to have you here to explain to our staff what this belief looks like. So it's sort of trying to, build trust even with that person. But at the end of the day, again, if they're insisting on stuff that we don't want to give or we think is like unprofessional, given our professional obligations, then we just have to explain it to more people. So sometimes it hurts and sometimes it helps, and There's no really predicting, at least in my experience, I can't predict it great. Sometimes I'm like, there's no way that that pastor really thinks this. And then he comes in and he says, that's exactly what we believe. I go, oh, dang. But sometimes you go, you know what? I read something, this only happened to me once ever, but I read something your Pope said, and it doesn't sound like this is what he meant. It sounds like actually he would be okay with us taking this tube out. Oh, okay, you can take it out then. Rare, very rare. You're not going to explain theology to a pastor better than they know it. So typically anyway. I did have a last case. I'll read it over quickly. I think we've probably gotten to a lot of it, but a different sort of patient. So Mrs. B experienced a series of seizures and is now sedated. During a family meeting, her neurologist floats the possibility of therapeutic hypothermia that might restart Mrs. B's neurological system. If this procedure doesn't work, the neurologist says, then Mrs. B will likely live the rest of her life in a minimally conscious state. The patient's oldest of 4 sons, Mr. K, exclaims, "We have to try it." When asked to expand upon this rationale, Mr. K at first isn't able to give a reason beyond repeating, "We have to try everything." Near the end of the meeting, he exclaims, "God will work a miracle for my mother if we pray hard enough. I know it. My brother and I will pray over her, and a miracle will happen. You can't disrespect me and my faith. It's discrimination." I'm sure you've never heard this. So how do you respond to that? Mm-hmm. Yeah, definitely. You can't pray anymore was not a good response.
Let's tackle that last thing first, which is, tell me about feeling disrespected.
Mm-hmm.
Right?
Yes.
In what way do you feel like your faith is being, sort of used against you in this situation? Let's work on that.
Yes. Yeah. So by no means are we trying to discriminate. Tell me about, what you mean by that and how we can maybe help. So tackling that, because again, this is probably about mistrust, right? So this is a power play, and you hear it all the time in pop culture and in medicine. It's discrimination to, my religious faith is my religious faith, and how dare you question it? Where does that come from?
My question about this case is, if the neurologist offered this as a therapy, was there not a medical reason to do so?
Mm-hmm.
Question why they would want the program?
Yeah, so we have to try it. They offered it. 99% of the time, we're just going to do it, right? So let's imagine that this is not what the whole healthcare team thinks is the best idea for this patient. So in my longer sort of version of this is a last-ditch effort by a neurologist who thinks this is a good idea, and nobody else agrees with him. So he's come to the family by himself, without the rest of the care team there, to pitch this, and now they won't stop talking about it, right? So now this family has heard this option, which sometimes is presented like this. Sometimes it's, wow, we could do a lot of things like this and this and this, but we don't want to do them. And I go, oh no, why did you offer it if you don't want to do it? Because now they think that this is a last-ditch miracle potential, right? So by even bringing it up, this is all they're going to focus on now. So let's imagine that the rest of the care team thinks this is a crazy idea, but this neurologist is prone to doing this sort of thing.
I also have an issue with how you reframe for a family, for a person. If we pray on it hard enough, it will happen. Because when it doesn't happen, does that mean they didn't pray hard enough?
Mm-hmm.
That they did something wrong? It's so loaded when somebody sets it up like this. It's like,
Mm-hmm.
you can't win this.
Right. Yeah, and so there's a lot of strategies for this. A lot of people will want to say things like, because you don't want to set them up to think that if they didn't pray hard enough, and if they had only had more faith, you don't want to necessarily reinforce that. At the same time, is it your place as a clinician to say, well, here's what prayer really is about. I think you don't really understand prayer. As a pastor, I might have said that to someone in my congregation, but it's certainly not something that, a clinician probably should be saying. So it's this fine line, right? I think you should continue praying, of course. Here's what it and I have no power like God has power. Here are the things I can do. Here are the things I'm professionally obligated to do or not do. I think you set yourself up to be in a bad position about trying to argue the merits of prayer or not. So I think there's an impulse to say, well, no, you need to think about prayer differently. But are you really willing to engage in that conversation? And some people are really good at that conversation, but it won't always go your way.
No, and I just worry for the children who, who have set themselves up.
Mm-hmm.
It's not that I think that we need to take that on or talk them out of it or anything. I just feel so bad.
Yeah.
Like, how are you going to cope when something bad happens to your mom? And are you going to think it happened because we were bad, or
Mm-hmm.
because you didn't pray hard enough?
Mm-hmm.
And it's not trying to talk him out of it. It's just such a bad presentation.
It is, yeah.
When you
yeah.
get it, because he's like, now what?
Right, and hopefully this person, if they say something like that, really does have a faith community, because most faith communities don't believe that if you had just prayed hard enough, you would have prevented death. Like, that's not really part of most people's theology. So if you can get somebody in from this community, if they have nobody, then you question whether the true sincerity of that statement. They could genuinely believe it and then have no religious community to back them up, but I think that those are actually pretty rare instances. This comes from somewhere. So if you can get somebody from that tradition to come in and talk with them, that might be helpful, or at least know that they are supported when they leave, because there's only so much we can do, right? Especially once they leave, they need a community of support to help grieve with them. So making sure that they have that from a person who maybe was coming to the hospital to do it in the midst of that is important.
You are disrespecting us in some way.
Right.
And on the first part, this is always been interesting to me, where the doctor says, oh, by the way, you ever heard about this technique before? And I'm going to take this one out of our toolkit
Right.
and offer it to you. And sometimes it's something that one doctor thinks what the other doctor's done. Sometimes it's a research protocol presented as if it were treatment, but really is and you sort of wonder what's happening when all of a sudden, oh, by the way, I get this.
Yeah, don't do that. So I think we've run out of time. Oh, yeah.
Oh, I actually was just going to make a comment that, I've been so impressed that when you go to funerals, there's none of this like, we didn't pray hard enough. There's like, we prayed and now our beloved one is in heaven. Like they, it's just amazing how, they can really, and I think that comes from the community and other people bringing them in to help support that family member, because they're so focused on this, let's just get them to keep living, whereas the other people can focus on beyond that.
Mm-hmm. That's a great point. So yeah, make sure other people are involved and hopefully then rely on them to pick up the extra work. But I think that maybe will help our distress to know that that is true. At the funeral, this is not the place where we're saying, if we had only prayed hard enough, he would still be alive. People come around. This is the most vulnerable place that they're in right now, and they say things maybe they didn't really mean. So we can take small comfort in that. All right, thanks everybody.
Thanks so much, Dr. Stahl, for coming. Like to get back to the car? Or
Yes.
Okay, I'll get you.
Okay. P2.
Okay, I can get
I have no idea where I am.
I will get you. It's actually around there.
Okay, good.
So I have this story, if you want to
Yeah.
borrow it. When I was like massively pregnant with my first child, we came in at like 3 in the morning from home to put in the baby. And I get in there and they've been doing impressions for like 20 minutes or something by the time I got there. And the grandmother's like shrieking and